So here we have a resistance, pressure, and flow. Here the change in pressure is equal to our volumetric flow rate times our resistance. And the resistance, you'll see here, is the driving pressure over flow, so you can realign the equation. And remember the changes. Yeah, so don't forget, similar to Ohm's law, the change in voltage, in this case voltage, is equal to the ampage, the current, times the resistance. So very similar to it, the same idea. Here you have volumetric flow rate, Q, equal to the flow velocity. And that's really just like an electrical current. That's what I is. Times the cross-sectional area, in this case the resistance. And the resistance is equal to the driving pressure, change in pressure, times, or divided by the flow, which is Q, or 8 times the viscosity, or the thickness, or the resistance, times the length, divided by pi, pi r to the 4th power, and r being, in this case, the radius, which is a cross-sectional area. So the total resistance of the vessels is always the resistance of all the chemicals or the currents added. Total resistance of the vessels in parallel are 1 over the total. Capillaries have the highest total cross-sectional area and the lowest flow velocity. Remember, they're small. And then pressure gradient drives flow from high pressure to low pressure. Obviously, you want to go, the higher the pressure, it'll push to a lower pressure, path of least resistance. Arterioles account for most of the total pressure and resistance. Veins provide most of the blood storage capacity. That's interesting to know. Not arteries, it's veins. Viscosity, or the thickness against the flow, depends mostly on the hematocrit, however you want to say it, different ways to say it. And that's the red blood. And obviously, if you have more blood under a smaller area, higher the pressure. Viscosity increases in hyperproteinemic states, multiple myeloma, and polycythemia. Viscosity can decrease with anemia. It just doesn't clot very well, so less viscous. And the compliance is equal to the change in volumetric, or V, or volume, time, divided by the change in the pressure. Also note the tendency of arteries and veins to stretch in response to pressure has a large effect on the perfusion, or the sharing of oxygen and the blood pressure. This physically means that blood pressure, or blood vessels with higher compliance will deform easier than lower compliance blood vessels under the same pressure and volume and conditions. Here's another way to look at the graphs: cardiac and vascular function curves. You'll notice here in one inotropy, these are changes in contractibility, altered cardiac output for a given pressure. And examples: catecholamines, digoxin, heart failure with reduced ejection flow, narcotic overdose, sympathetic inhibition. Here, cardiac output, venous return. You'll notice the vascular function curve scales down as right arterial pressure increases. The intersection of the curves is the operating point of the heart. And then you have venous return. Changes in circulating volume, or venous tone, will cause an altered right arterial pressure for a given cardiac output. The mean systematic pressure, the X horizontal, changes with volume over venous tone. Here you'll see the increasing volume, and then the tone, it plateaus. Okay. And then here you have the total peripheral resistance, okay. C. Here you have vasopressors, will push down, and then the exercise rates at any given mean systematic pressure and x-intercept going across. And pressure changes in the total pressure will cause a change in your altered cardiac output. See, so notice the cardiac output is going down on each of these. So changes often occur in tandem, but may be reinforcing when you increase exercise, inotropy, total pressure, and to maximize cardiac output. Or it may compensate. Heart failure will decrease inotropy, therefore you have fluid retention to increase your preload and to maintain your cardiac output. So there you go, cardiac output. Okay. Here you have pressure volume loops and cardiac cycles. You have your left ventricular volume, okay. And here you go. So the black loop represents the normal cardiac physiology. Okay. This is on your USMLE, by the way. They'll ask you about 1, 2, 3, 4, or 5, and they'll ask you what's occurring at one of them. You have to know which one it is. So make sure you always start on the right, just like the way your heart is, in a sense. Volumetric contraction, the period between the mitral valve, and remember the mitral valve is also known as the bicuspid. It's the second valve on the left side of the heart. Closing an aortic valve opening, period of highest oxygen consumption, right here. Systole, ejection, period between the aortic valve opening and closing. So here you close, and then you open, and it's this is preload. I mean, you got to push it out. Remember, systolic is pushing it out to the body, to the lungs. Volumetric relaxation, the period between the aortic valve closing. Remember, when the valve closes and the mitral valve opens, that's when you're filling the heart again. So right here. And then 4, rapid filling. This is more associated with your diastolic, the relaxation. And when it relaxes, what happens? The mitral valve opens, blood comes in. Rapid filling period just after the mitral valve opening, and then reduced filling period just before mitral valve closing. Starts to fill up the heart, and then you start it over again. When the mitral valve closes, you're up here. When the mitral valve closes, you're going to contract and push it out. Okay. Right back to 1 again. Here's another way to look at it. Heart sounds. These are on the test for sure. S1 is the mitral and tricuspid valve closure. Remember, it closes, so it can fill. The loudest at the mitral area, S1. So if these are closed, the aortic and pulmonary valve, S2, aortic and pulmonary valve closure, that's S2. So here you're contracting, you're going to push out. Remember, systolic is what? Pushing out, contracting. It contracts, it pushes everything out. S3, now we're in the diastole. Okay. This is in the early diastole during rapid ventricular filling. So now you're filling up your ventricular chambers, increased filling pressures. You may have some mitral regurgitation going back into the left ventricle. And more common in dilated ventricles, but can be normal in children, young adults, and pregnant women. And then the late stage here, or medium moderate, I guess, stage, in the diastole, these are atrial kicks. Best heard at the apex, again at the top point of the heart, with patient in the left lateral decumbitus position. High atrial pressure. Okay. And associated with ventricular non-compliance, hypertrophy. Okay. And then left atrium must push against a stiff left ventricle wall. Consider abnormal regardless of the patient age on your S4. And then here, reduced ventricular filling is going to be your S5. And then it kind of starts over again. The jugular venous pulse, JVP, there's an A wave. Okay. Oh, by the way, make sure that we understand the S1 here. These are the heart sounds, S1, S2. They ask you, they link these together a lot. Isovolumetric contraction is an S1, that's the start. The relaxation is the start of diastole, and that's S2. And don't forget, it's the same as lub-dub. A wave, atrial contraction. Okay. So we're talking right here. Atrial contraction absent in atrial fibrillation. Because remember, in fibrillation, there's no real pushing of the blood. It's not consistent. Kind of vacillates. Here you have the C wave. Contraction of the right ventricle. Right here. And this is your ECG, by the way. This is what your heart should be doing. These should all be aligned. So this is all fair game on the test. They'll say systole, here you're doing contractions. What should be looking at the heart? Well, that's the beginning of S on the QRS ECG chart. X descent, downward replacement of the closed tricuspid. Again, the tricuspid is your right and atrium and right ventricle. Have during rapid ventricular ejection phase, reduced or absent in the tricuspid regurgitation and right heart failure, pressure gradients are reduced. And then you have your V wave, which is right here. Now we're in the diastole. You have an increase in your tight atrial pressure because why? The lower ventricular are starting to fill. So V, villing or filling, however you want to say it. So that's a good way to remember it. If you put a V instead of filling, villing, kind of sounds the same against the closed tricuspid. It closes so you can build up pressure, in other words, and fill it up. And then when you have a Y descent, emptying of the right atrium into the right ventricle, prominent in a very constrictive pericarditis and absent in cardiac tamponade. Again, tamponade being the fluid around the heart, very abnormal.